From the JAMA Network, this is the JAMA Medical News Podcast, discussing timely topics in clinical medicine, biomedical sciences, public health, and health policy, featured in the medical news section of JAMA.
This is Jennifer Abbasi for JAMA Medical News. My guest today is Dr. Katherine Tuttle, Chair of Kidney Week, the American Society of Nephrology's annual meeting, which just took place in Houston, Texas. Dr. Tuttle is a professor of medicine at the University of Washington and executive director of research at Providence Inland Northwest Health. And she's here to discuss clinical research highlights from Kidney Week. Welcome, Dr. Tuttle.
Thank you. It's great to join you this morning, Jen.
As we're recording, Kidney Week just wrapped up yesterday. Hopefully you've had a few minutes to catch your breath, and we appreciate you making the time.
My pleasure.
I'd like to start with a study presented at the meeting that provided updated estimates on chronic kidney disease. The researchers analyzed data from the most recent Global Burden of Disease study, and according to their estimates, 788 million adults around the world now have chronic kidney disease, about 400 million more than in 1990. The age-standardized prevalence of chronic kidney disease has risen 3.5% over that time frame and is now about 14%. Can you talk about what's driving this increase and what it means for patient care?
Well, thanks, Jen. I think it really is a very important public health problem and one that's been largely under-recognized. And this report really shines a light on the enormous public health burden worldwide. And I guess I would add to that, chronic kidney disease is now the 9th leading cause of death in the world, and one of only 2 that's actually still increasing within the top 10. And they're projecting that by 2050, if things don't change, will be the 5th leading cause of death. So it's enormously important. In an epidemiology study, we can't really answer questions about why, but we can look at associations. Part of it's related to an aging population, but a big part of it is the obesity and twin pandemic of diabetes, which are the most common causes of chronic kidney disease. In fact, diabetes is now responsible for half of all CKD in the world. So while prevention of diabetes would actually be a tremendous solution to the CKD problem, we have to face the reality that diabetes is increasing in parallel and that people living with diabetes are going to develop chronic kidney disease. And so it really shines a light on the need for awareness, detection, and intervention strategies, because besides the human toll, the cost of this disease is enormous, and it really can break health system budgets as well.
Okay, moving on, 2 meta-analyses presented at the meeting and published simultaneously in JAMA looked at SGLT2 inhibitors and kidney outcomes. Their findings seem to suggest that broader use of these medications may be warranted. Can you talk to us about these studies?
Yes, these are very important studies. SGLT2 inhibitors are now first-line therapies for virtually all forms of CKD. And what they've done is provided reassurance that that recommendation is correct. They pooled data from the major SGLT2 inhibitor trials across diabetes, cardiovascular disease, chronic kidney disease, and basically show irrespective of the presence or absence of diabetes, irrespective of the severity of kidney disease, and even in people with minimal evidence of kidney disease, that these agents are highly kidney protective, reducing risk of kidney failure by 40% and risks of accompanying cardiovascular complications, particularly heart failure, by about 25% and all-cause mortality by around 20%. So if we want to really address the epidemic of CKD, SGLT2 inhibitors are one of the best arrows in the quiver, and I think that's reassured us about that and really points us in the direction of now we need to implement these therapies in very broad populations of people with and at risk for CKD.
The next study we'll discuss was a clinical trial that investigated whether fish oil supplementation has cardiovascular benefits in people receiving hemodialysis. Why is this an important question?
Well, unfortunately, the hemodialysis population suffers a very high mortality rate. For example, people with diabetes, which we've already talked about, who end up with CKD that progresses to kidney failure and need for kidney replacement therapy by dialysis, have a 2-year mortality rate of 50%, and it has not changed in decades. I mean, that goes far beyond many conditions that we recognize as fatal. And despite many efforts at interventions, we have had none before this that have shown a mortality benefit. So this was considered to be very important because of the mortality benefit and the fact that it's a relatively simple and inexpensive intervention.
Okay, so tell us a little bit more about the trial design and its findings.
So this was for people on hemodialysis, and they were randomized to either a fish oil supplement or a placebo. And they showed, a 50% plus reduction in mortality and, very high rates as we had known about for a long time. And so there was a lot of excitement about that. That paper also published simultaneously, this one in the New England. And there's a lot of interest in this because conventional treatments for cardiovascular disease, such as statins, do very little for the dialysis population. And so this is considered to be quite a breakthrough because this is a population at high risk and a huge unmet need for interventions that particularly reduce cardiovascular risk, which is the main driver of the mortality.
So, what do you think the implications of this study are? Is this something that's going to be changing clinical practice?
Well, in my opinion, yes. I think that there will be lots of questions, as there should be, about the trial. How generalizable is it? Can it be reproduced? But in the meantime, this is a therapy that's safe, it's inexpensive, and there's little downside to prescribing fish oil while we continue to investigate it. But considering the large mortality benefit, in my opinion, there's nothing lost by doing it. And if it proves, if other data are different, we can reevaluate the recommendation to use fish oil. But with the striking data that they showed, I think its time has come. And we finally have a win for saving the lives of people treated by dialysis.
Staying with the topic of hemodialysis, another trial aimed to determine the best dialysis strategy for patients with acute kidney injury. This study was also published simultaneously in JAMA. And the question was whether a more conservative dialysis strategy would improve kidney recovery for these patients. What did we learn?
Well, the study showed that a more conservative strategy, maybe we should say what that is using dialysis as clinically indicated. So that would be for taking care of excess fluid or high potassium or other electrolyte or acid-base disturbances versus just putting someone on a standard 3 times per week schedule. And in the study, they ended up using dialysis about twice per week as opposed to 3 times per week and for specific clinical indications. And they found that this more conservative strategy was associated with a higher rate of recovering kidney function and more days off dialysis after they were released from the hospital. And so this is very promising because it shows that a more conservative approach might actually be healthier for kidney recovery. And there are a lot of reasons for that. Dialysis can cause low blood pressure in particular that might actually exacerbate the acute kidney injury that we're trying to treat. And so I think this is very important and it is practice changing because it will direct clinicians toward as needed dialysis as opposed to routine dialysis. And I guess in a sense, you could think of it in a very sort of practical way of a precision medicine strategy.
Right. Okay. Now let's talk about another patient population, people with type 1 diabetes and chronic kidney disease. A clinical trial tested the drug finerenone in this group. Now, this drug is already approved for chronic kidney disease in type 2 diabetes. What did we learn about its use for type 1, and why is this important?
Oh, thanks for that question. No, we start out talking about the worldwide burden of diabetes. And while 90 to 95% of the worldwide burden is type 2, the remainder, 5 to 10%, is type 1. And that's still a large population of people. The prior clinical trials of the new kidney protective therapies have been conducted in people with type 2 diabetes. It's a large population, they're recruitable, and in a relatively short period of time, we can test for a true clinical outcome like major loss of kidney function, kidney failure, death. The type 1 population is much smaller, so it's harder to recruit enough people to get to those true clinical endpoint outcomes. And so they've been left behind. Yet 3 out of 10 will still get chronic kidney disease and with the same progressive course that leads to either kidney failure or death as in type 2. So it's very serious and it's been unaddressed for type 1. The last new therapy for CKD and type 1 diabetes came to us over 30 years ago. the 1993 captopril renal trial. And since then, they were essentially left behind. So this is the first positive trial in type 1 diabetes in over 3 decades. And it used a unique design strategy that was endorsed by the FDA called a bridging biomarker strategy. So walking back to the type 2 diabetes studies, what that means is that when they looked at the type 2 diabetes trials and did statistical analyses on was there a biomarker that would basically explain the clinical benefits. So the long and short of it is they showed that 87% of the benefit on the clinical outcome, so kidney failure, death, loss of kidney function, could be explained by albuminuria lowering. So the FDA said that they would accept a trial for registration with albuminuria as the outcome and really framing it as a bridging biomarker, that we could reasonably assume that if the albuminuria result was similar to the type 2 population, that it's more likely than not going to be correspondingly clinically protective. So that may be technical, but it was critical to getting this trial done. And it was a win. So in this population with type 1 diabetes and CKD, they had a 25% reduction in albuminuria, which maps almost 1-to-1 to the risk. So if we did a big trial, we would power that for about a 25% risk reduction in the clinical endpoints. It turns out to be conveniently aligned in that regard. And the drug was safe. It was well tolerated. It is a short study, 6 months, albuminuria lowering. We acknowledge all that, but that's probably about as good as we're going to be able to do for type 1 diabetes. And of course, decisions about drug labels will come later, but the type 1 diabetes community has its first positive clinical trial for kidney outcomes in 30 years.
That's exciting. We always love to hear good news like that.
Mm-hmm.
Finally, the last study we'll discuss involved patients with type 2 diabetes. This was a study that looked at whether real-world use of semaglutide, the GLP-1 drug, was associated with a reduced risk of kidney complications in people with type 2 diabetes and early diabetic kidney disease. How does this add to what we know about the kidney benefits of GLP-1 medications?
It's a really important study. Last year, we had the one and only dedicated kidney outcomes trial, the GLP-1 reported, the FLOW trial, which to my test of reason is one of the biggest wins yet, because not only was there a benefit on that same kidney outcome, but because they have such high cardiovascular risk, FLOW also showed a 20% reduction in MACE and a 20% reduction in all-cause mortality. But they included mostly high and very high-risk patients. So this study took advantage of real-world data from electronic health records to look at what happened when semaglutide was used more broadly in people with diabetes. And since it's used for other indications like weight management or blood glucose control or even cardiovascular risk reduction, there were quite a few people without kidney disease or with very early kidney disease who were treated with these agents, and they could compare them to similar patients who weren't treated with them, where I think they compared it to a DPP-4 inhibitor, and almost reproduce the FLOW results on the kidney outcomes. And so I guess where we're moving, which is very exciting, is more to prevention strategies. So, of course, real-world data has its warts and blemishes, but, it's probably the best we're going to get for more of a prevention study, at least in the near future. And it reassures us that not only are these agents likely to be protective of kidney function in the more advanced stages, but now we have the opportunity in this very high-risk group with diabetes, which is driving most of the CKD in the world where we started, with agents such as this to prevent those complications. So I think it's a very nice complement to the clinical trials. I think that's how we will use real-world data, also for safety signals. But, this is an important paper, and it gives us very useful information about additional benefits beyond metabolic and cardiovascular benefits to really reduce the chance people will have serious kidney problems as well.
Now, do you think a randomized clinical trial would help support these data, or are you pretty convinced?
Well, of course, randomized trial data is always our best evidence. I think the real question is feasibility and cost of doing a study like that. I mean, of course, I would like it. But the other thing, too, is that there are other sources of data that can be used, like clinical trials that were conducted in people with type 2 diabetes for hyperglycemia or the cardiovascular outcome trials. And there we had randomized groups. And most of them do have measures of kidney function, and many have measures of albuminuria. And that's an opportunity to explore those data sets. And I think if you had those analyses alongside the real world data and flow, that would be a pretty strong argument for prevention.
Okay. Well, thank you, Dr. Tuttle. Really appreciated speaking with you today. And again, thank you for making the time for us.
Well, thank you. We had an exciting Kidney Week. We have a renewed spirit of innovation and impact, and we really appreciate JAMA highlighting some of the terrific science, but also real wins for patients and communities. So it's an exciting time in our field, and we're grateful to see it featured in your podcast.
Thank you. That's it for Clinical Highlights from Kidney Week. I'm Jennifer Abbasi, Director of JAMA Medical News. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening, and join us again next time.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.